How do we know if a child needs myopia management? Needing glasses for distant vision is a sign, but it's not the whole picture. Family history also plays a role. That's why in this episode, we'll explore the essential assessment tools we can use in our clinics to effectively assess a child's risk of myopia progression. My name is Shafiq and I'm an optometrist and I've been managing myopia now for like the past 5 years. I'm really fortunate to be here in Australia where I actually do have access to all the myopia management options, all the myopia control options. And me personally, I have actually prescribed most of the common ones anyway. Now, I was once a young optometrist and I do understand how challenging it is to manage myopia because I was also pretty clueless. Like, when do you start managing myopia? Like, what are the things that you need to look out for? And that's why this episode is actually pretty important. And we're going to go through all that stuff. So I want to help you guys out there because my mission is to really help optometrists and eye doctors who are not yet confident to be really confident and know how to effectively manage myopia in your patients. Quick disclaimer. All information, content, and material of this podcast are the opinions of the speakers and as for the informational purpose only, and not intended to serve as a substitute for the consultation, diagnosis, or in medical treatment of a qualified healthcare provider. So let's get straight into it. Now, let's talk about why does assessment matter? Why is it important for us to do a very comprehensive assessment when we want to diagnose myopia progression in children? The reason why it's important is that this really sets as a baseline. It sets as a baseline as to whether our patient, how aggressively in inverted commas, I would say, that we are going to be treating them. Well, when should we really start it? I mean, the way that I see it, as long as someone's a myope, it's good for us to have that conversation straight away. Be it we want to manage it, be we want to intervene straight away or not. Now, that's another discussion that we actually have to have with parents most of the time. Yeah, but we know that if we can comprehensively assess the kids when they're in our chair, like the things that we have to really go into, like in terms of maybe the history taking, the questions that we want to ask parents, the tests that we want to perform in the room itself, not just vision, but also in terms of their binocular vision, in terms of their eye health itself. What are those things, And if we do all the different tests that we then we would have a really good idea. We'll have a really good idea as to where the child sits and as to whether they are like low risk, medium risk, or high risk for myopia progression. Now, I also do want to highlight the role of the assessment in determining which is like the most suitable approach for them. This is a bit of a tricky topic to talk about because depending on where you are around the world, I do understand that not all myopia management options is available everywhere. So for instance, optometrists in Singapore, they do have access to like the atropine, not to atropine, they do have the orthokeratology, myopia control glasses, MiSight contact lenses, but they cannot prescribe atropine eye drops on their own. So they actually have to refer off to their ophthalmology colleagues in order to get that sorted in a way. Here in Australia, yes, as optometrists, we pretty much can prescribe everything. Now, this month is June of 2024 that I'm recording this particular episode here. And from what I understand is that even in the United States at the moment, my colleagues over there, the eye doctors, they actually do not have access let me just clarify, the ODs there, right? Not to confuse with the ophthalmologist. Yeah, you do not have access, or is not maybe FDA approved yet to use like myopia control spectacles. And yeah, I think that's probably the main one. Yeah, the myopia control spectacles in a way. So there is orthokeratology, there is atropine drops, and potentially MiSight lenses. Yeah. So don't quote me on this, but I do know that myopia control glasses is something that's not there just yet. Yeah. So hopefully, in the future, as time goes by, you guys will have access to all this good stuff also. So yeah, so that's why it's important to know what are the tools that you can use to treat or to start treatment for your patients in a way, but also take into account maybe what options is the most suitable for your patient. But before we even get there, the thing that we have to look at now at this moment is how do we assess them effectively? So that's where we're gonna go into the all the essential assessments and the tools that you might need in a way to be able to assess them effectively. So first thing, let's talk about history taking. Okay, so history taking is actually pretty straightforward in my opinion. There's two ways to go about doing this. First way is, of course, you talk to the parents themselves. The other way is actually giving out a questionnaire. Now, why would a questionnaire to some extent be a bit better? Because when there is a questionnaire right there and parents fill it out, they are filling it out without talking to you. So they are usually a bit more honest on the questionnaire. And because before they see, right, whatever that they write down, they would not be able to gauge maybe from your reaction as to, okay, is this good or is this bad? So I actually remember this one particular parent. So we, the parent came in. We have not yet done the questionnaire, but then when I was talking to the mom, I was like, hey, so how long does your child spend on screen? So she was like, oh, maybe 4. And then when she said 4, I was like giving this reaction of like, whoa, that's quite a lot in a way, in a sense. And then she was trying to downplay it a bit, and then, yeah, so it was one of those really funny reactions, I would say, that I sometimes get from parents. So yeah, sometimes just doing like a questionnaire might be a bit better. But of course, I'm not saying that that's the only way to do it. You still can bring them in. You can just ask them questions. That is still fine. But some things that we do want to ask is firstly about maybe the age of the child, all right, just to know how old they are. But you would know that anyway from their date of birth when you take their details all in. Hey guys, real quick, if you're an optometrist or eye doctor early in your career and you want to learn how to assess myopia risk effectively in kids, download my free PDF toolkit. Inside, you'll get a questionnaire for parents to fill out, a checklist of in-room tests to perform, and a comprehensive myopia risk assessment table to further understand your patient's myopia risk and to determine whether to refer or manage them. Now, you can go and click on the link in the description down below and take your first step towards becoming a myopia management specialist. And now the next one is the ethnicity. Now, this is a bit of like a touchy topic, and I know that some people won't really ask it outwardly, but just by seeing the child, you would kind of know in a way. But we do know that there are certain ethnicities that do actually progress much more. In particular, like East Asian kids, they do actually progress much more than probably the other kids in a way. So for instance, the Caucasian or Hispanic, they do not really progress as quick as the East Asian kids in a way. Yeah, so that's just something that, and that's why I like to write that in the questionnaire itself. Yeah, so because when they fill it in, then it doesn't feel too personal in a way. Instead of you just kind of like judging. Yes, there are some instances where you will run into it where they're like, so maybe mom is Asian, but that is Caucasian. So in this case, what do they put the kid as? I usually just say, just put both down. It's fine. It's okay. Yeah. So it's just one of those things. But again, if you do not really want to ask it, I'm not really gonna like say that it's like the worst thing ever, because at the end of the day, if they do have myopia, we do want to manage them. Now, next thing is also like amount of time they spend on near work activities. We know that this is directly correlated to how bad their myopia can progress in a way. Yeah, so the longer they spend on screens, the worse it is, like in theory, right? So, of course, what's best is less than 2 hours on screens apart from like school and probably homework and all that stuff. Yes, it might be still excessive for some kids, but at least it gives us some sort of an idea and some sort of a baseline as to what we should be looking at. Now, outdoor time, 2 hours, more than 2 hours outdoor every day. And this can also include like recess in school or like breaks that they have in school. That can still be included inside it because they wouldn't literally be like staring into anything close up or into the classroom. They'll be a bit more outdoors. At least that's what we hope is happening. So yeah, so let's just take that into account. And also, if they happen to be maybe walking to school and coming back home from school and they do it on their own, I would still consider that as like outdoor time in a way, so that yeah, so that we can have a true idea and a true picture of how it is. Now, the amazing thing is that yes, weekends are time where usually kids get to naturally spend a bit more time outdoors when their parents bring them out or they're out playing with friends maybe. Yeah, so naturally on the weekends it is a bit more. So when you ask that question to parents, just try to trigger all these different things. Just try to ask them. Yeah, so those are the things. And also about recent prescription changes. Now, in terms of the amount itself, some parents are really on it and they know, so my child last year the script was probably like a 225. This year, it seems to be a 275, but the year before was like maybe a 150. Like they're really on top of things. But I would say that most parents do not really know how much their child's vision has changed by. Now, if the child has been seeing you for quite a while now, you would have their records already. So that really does make it much more helpful. But if you do not have their records, that is still fine. That is still okay. Because what you can do is that you can kind of track, okay, from their current glasses, you can vet or measure out the prescription in the current glasses, and then you can have a look at what their prescription is today to see if there's any progression in that sense. We are going to be talking a bit about like measuring axial length, as that's kind of like the gold standard these days of myopia management when it comes to tracking the progression, but we'll chat about that a bit later. So now let's move on to the clinical examinations that will be done in the room itself after asking all those other history questions. Yeah. So now testing visual acuity, this goes without saying. Every single patient that we bring in, whether it be an adult or a child, will check their vision. And I do like to check their vision without glasses just to have a good idea of how bad it is. Of course, if they're like current prescription, is like a -6, don't bother really checking the unaided in a way because it's going to be pretty bad. But then, yeah, so if they're like maybe low-ish myopes, I would say anything above -4, usually I would just like to have a good idea of how they're seeing at the moment without their glasses. And then, of course, we check vision with glasses. So that's one eye and then both eyes in a way. And then after that, in the practice that I work at, we do get their auto-refraction results straight away. But it's also a good idea to do red on the kids, especially on the younger ones, because we know that there's a bit of accommodation that is usually in play. And by doing retinoscopy, it is actually much better so that you have some sort of an idea. A bit of a pro tip in a way that if you get their current glasses and they're not reading too well already, you can kind of like just put a working distance lens on top of the right and the left eye and then do a quick red so that you'll have a good idea of like roughly how much the prescription might have gone up by. So yeah, so retinoscopy, very important. And of course, the most, arguably, one of the most important tests to be done is the subjective refraction, because this is where we'll know if there really is a progression. Now, subjective refraction is very important for us to do it well because we want to make sure that we're not overcorrecting them. But if anything, we want to make sure that we're not undercorrecting them because undercorrecting myopia has been shown to actually increase the rate of the progression even more, and we do not want that. So back where I'm from, again in Singapore, when I was younger anyway, there used to be this thinking among parents that like, okay, if my child is like a -3, maybe just prescribe a 250 because you don't want to get used to that higher prescription. And guess what? Unknowingly, our vision get worse and worse and worse over time. Case in point, me. Now, I don't think my parents ever asked for an undercorrected script, But who knows? Maybe the practitioner who was prescribing my prescription might maybe prescribe it a bit lower. All right. And of course, I was a kid back then. I had no idea. I wasn't even like interested in optometry back when I was really young. So that could really be it back then. Yeah. So measuring subjective refraction is very important. And one tip that I can give is actually on using duochrome, which I would kind of personally, I try to stay away from it from kids. And this is just because of a personal experience that I have, which is that growing up, and actually till now, I love the color green. All right, as you can tell, I'm even wearing a green shirt right now. If you're watching the video of it, yeah. And I used to always say green, 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 green. Although we know that technically which one is clearer, red or green. We do want to say no. Sometimes say red also because we don't want to be over minusing our patients in a way. Yeah. So just be careful. I'm not saying that all kids are gonna be like me back then, who always said green even when I saw the red was clearer because maybe I didn't understand the test too well. I prefer doing like a +1 blur on kids in a way because I get them to compare between the two eyes just to see which one is clearer than the other one. And then slowly add a bit more minus until they can see the 6/6 or the 20/20 perfect vision line. So that's how I would do my refraction anyway. But the other thing also, if they are currently wearing glasses, again, check what their vision is in the current glasses monocularly, and then you'll have a good idea. So if they're only like one line above 6/6 or 20/20, you know that maybe there's an 0 to 5 progression, and then anything more, you can kind of have a good idea. All right, so that's also very important. Let's talk a bit about the use of cycloplegia or cycloplegics in a way. When do we really want to use it? Over here in Australia, the main one that we use is cyclopentolate. And it's, I would say that if it's the first time the kid is having glasses or is their first eye test in a way, and you just want to make sure that if they're myopic, they're truly myopic and it's not any kind of pseudo myopia, always cyclo them. So first appointment, never wear glasses before. It's very important for you to cyclo the kids because you just want to relax their accommodation, and then so that you can really know truly what prescription they have. And again, I know that in some countries, you might not have access to cycloplegia. It's fine, but I would say that when you're doing the refraction, just make sure that you manage to really plus them as much as possible. If you can refer to your ophthalmology colleagues to do a cyclo, that would probably be a good idea too, because we know that like as the kids progress over the years, as they get older, using cyclo is a bit less and less important. Yeah, so that's just one of the things to take note of in a way. So first appointment, if I see a kid, maybe like a 6 or even a 7-year-old, or even if they're 5 or a bit younger, I would cyclo them because I want to make sure that their eyes are really as relaxed as possible. I would do retinoscopy, so just to make sure that again it's not being overcorrected. Auto refraction also helps after cyclo, so that you'll have a good idea of where they are sitting in a way. Now, the next bit is talking about binocular vision assessment. I think this is something that's a bit more underrated in a way, although with kids, we should never ever not check their binocular vision. Now, firstly is of course to check for any ESO or exophoria, especially at near, I would say, because that's where, you know, when they do most of their reading and all that kind of stuff. And any kind of ESO, maybe one ESO, you know, it might be okay, but also different school of thoughts here. If there's any ESO at all, that's something that, you know, we do want to help the kids with in a way, so that to make sure their eyes are not really like crossing over when they're reading, right? Going crossed eye in a way. And also, yeah, if we do see anything like an intermittent exotropia, just know that with these kids, we have to be a bit more careful, just because there has been studies that show that their vision actually do progress much more quicker, all right, than kids who maybe have normal binocular vision function. And of course, when we do the cover tests and all these different tests that we would normally do, we just want to make sure, we just want to check that there is maybe no strabismus that we might have missed, any obvious tropias, which we really shouldn't miss any tropias. And, when doing pupils assessment, just to make sure that the pupils are fine, everything is nice and well. All right, yeah. And I would just like to touch on probably two tests that might be kind of crucial or would be worthwhile doing. So number one is actually MEMRET. Okay, so this is the monocular estimated method. I think that's what it's called. But this is basically where you get the child to put on like their proper prescription, all right, their full prescription in a way, and then you do get them to look at a near cut on your retinoscopy, or maybe just a couple letters, so that you have an idea of how much they're accommodating up close. Now, anywhere from maybe 0.50 to a +1 might be considered normal, but if, let's say, they have a really high lack of accommodation, now that's something that might also point to the fact that their myopia can progress probably a bit quicker. All right, yeah, so there are also like some other ones that you can potentially do. So like, for instance, measuring ACA ratio is also the other one. So that's the accommodative conversions to accommodation ratio. Now, some studies really show that if they have high ACA, it might show that they might progress more. But some study shows that it doesn't really affect it much at all. So just take that with a pinch of salt, I would say. Yeah, but again, binocular vision assessment is something that we should not overlook at, especially because these are young kids in a way, all right? Now, let's talk a bit more about the ocular health itself. What are we really looking out for? So we have to look at firstly the anterior eye. We have to make sure like the lid lashes, the cornea is fine, the conjunctiva, that everything looks okay. No signs of dry eyes also. We know that with kids, dry eye is not as common, but don't be surprised because these days I have seen a lot of kids. I've seen too many kids who actually have dryness in their eyes because they are using a lot more screens than probably we were when we were back in when we were younger back then, or I mean, probably some of you guys are much younger than me, I would say. So probably back in my day when I was young, I did spend time on screen, but I don't think it's as much as kids these days, probably. I don't know. I'm just like, guessing in a way. So we just want to make sure the anterior eye is fine. And some conditions that maybe we want to look out for is keratoconus. So keratoconus, we know that it can also it's because of the thinning, there's a bit of thinning that's on the cornea itself, and it can cause usually higher astigmatism, but also it can cause high myopia. So just take note of that, all right? That the astigmatism in kids, we do want to also monitor and progress it, just to make sure that it's not just myopic progression, but if they have increase in astigmatism over time, that might be leading to us thinking that there might be some systemic issues maybe that they might have. Because if they do have keratoconus, then there are other things that we just want to check and look out for. So, for instance, like Marfan syndrome, Stickler's syndrome. Just a bit to touch on that. About 2 weeks ago, I actually met two of my patients. No, let's not say two. It's actually one of them. So one of my patients came in. She was in her 40s, and she does have Stickler's. She does have really high myopia, but the thing is that when she was in my chair, she was only like a -1. And we realized that she's done her cataracts already. So that's why. Now, her daughter, who was there with her, is probably much younger, maybe at most in her late teens or maybe early 20s. And she was wearing a pair of sunglasses indoors. And I was wondering why. So firstly, they did tell me that, yes, Stickler's does run in the family, but also for this particular patient, or that particular patient's daughter in a way, she had a retinal detachment also not so long ago, and like her vision is just a bit glary at the moment. So I'm like, oh, okay, cool. So just to kind of understand as to why some of our patients are doing what they're doing. So yeah, keratoconus, definitely check for that, just to make sure, like, even when you're doing retinoscopy, you can actually see if there's any kind of like scissoring reflex on the that you get when you look through the retinoscope. If you see any of that, do perform a topography so that you can have a good idea just to see how their cornea is in a way. All right. So yeah, so those are some things that we want to check in terms of anterior eye itself that would be more common in a way. Let's talk a bit about the posterior eye itself. Now, for the posterior eye, we just want to make sure that, especially because they are kids again, that there's not really any abnormalities. Usually, I would say that with most kids, when they are really young, it would have been screened for anyway. So it would not really be much of an issue. With most of the kids, we know that when they're young, it will be checked for already, like retinopathy of prematurity, any retinoblastoma. So all the different things is probably checked when they're really young. So when they present in your chair, usually there shouldn't be any of those issues in a way. All right. Yeah. And next, let's talk about the very important and maybe slightly controversial of like measuring axial length. Okay, so when I was, I'll just share a bit of my story. When I was initially starting to manage myopia 5 years ago, I did not have any access to a biometer. So I wasn't measuring axial length for quite a while. And when I chat with some of my colleagues who do have access to it, or maybe some of them own their own practice and they buy it, I do feel envious. I do feel like I'm less of an optometrist when I'm managing myopia just because I don't have it in a way. But again, that did not stop me. That did not stop me from managing myopia to the best of my abilities, because for like 3 years and a bit, I did not have any access to a biometer. Yeah. So only when I had access to it, now that I find that, firstly, measuring myopia progression is much, much easier. Secondly, talking parents into starting myopia management treatment for their kids get much, much easier. And also overall for them to be able to see like, their kid's eyes is this much and now it's this much. They know that like they're doing what's best for their kids in a way. And also as a practitioner, it does make things much more easier for you when you have this measurement. And let's dive into it. Why is the reason that axial length really matters in myopia? Because we know that in myopia, if accommodation is in play, the prescription that you get might not be the most accurate. But with the axial length, or measuring the axial length with a biometer, the one that I use is an optical biometer. Yeah, so it is really accurate. Number one, it is repeatable based on the studies that has been done out there. And number three, also, accommodation is not in play. So because the kids, even if they try to accommodate, it doesn't matter, because this is measuring the physical length of the eye itself. And we know that we can trust this as a measurement to use as like a baseline, so that in the future, if there's any progression or not any progression, we can be very confident that it's not the kids in the testing room who are over accommodating, hence leading to a higher myopic prescription, but it is really the eye physically itself growing. Yeah, so those of us who do not have any access to a biometer, again, you're not less of an optometrist like how I felt back then. You still have to manage it. You still have to do your best. If you guys have listened to a previous episode that I posted about one of my first ortho-K patient, I did not have any access to a biometer, and when I measured her axial length, when I had access to it, we were so glad that we started her on myopia management treatment, because her axial length at the age of 13 years old is 26.19, if I recall right, and the other eye is 26.14. Yeah, it was definitely 26.1 something, so just a bit high in one eye than the other one. Yeah, so just take note of that. Just really take note that, yes, although measuring axial length is important, and I do strongly believe that all optometrists, if you do have the machine or do have the capability of measuring axial length for your patient, definitely do it. But don't let that stop you from starting to manage myopia in your patients, because you'll be doing them much more of a service by managing the myopia by not doing anything at all. All right, and I'll maybe briefly touch on this particular measurement in the eye that is maybe worth considering having a look at also, which is the curvature of the cornea. Now, there has been, I'm pretty sure it's a bit more anecdotal in a way where there have been patients who have maybe like mild to moderate myopia, and because of the fact that they have flatter cornea, it kind of masks the excessive growth of the axial length in a way, so it might not really show that they have as long of an axial length. So they might be like a minus 350, but maybe have a slightly flatter cornea, or maybe like 8.2, 8.4. I'm not really sure like what is considered flat in a way, but something flatter than what you would normally see. And this is not on someone who's done LASIK. So that's how their eyes naturally are, that they do tend to have slightly shorter axial length. All right. And we cannot think that, okay, so if they have like flat corneas and they have like not long of an axial length, it means that they're okay, that their myopia might not be progressing much. But just to take note, again, this is not something that I would say we look at for every single patient. And again, the cornea, when we look at it, like I mentioned before, more to check for any pathology, but also just be wary of flatter corneas, that it might sometimes mask some of the axial length growth in a way. All right. Yeah. So, the other thing that I do want to talk about also, which, we have gone through a bit of it in the beginning, was also a bit about the family history, just to understand the what is the risk. Like, this mom and dad both have myopia. Do they both have high myopia? Or if they do not have it, yeah, that's great. But then also, I'm a huge case study where environmental factors actually caused me to be a high myope, and both my parents do not need glasses for their everyday. So they have probably a bit of astigmatism, maybe slight hyperopia. That's it. Now, of course, they have presbyopia, but they're not really using reading glasses as much. So, but that's not the story. But yeah. So we can tell that environmental factors, especially these days, does play a part in terms of myopia progression itself. All right. Yeah. So I do want to put a bit of like a sharing as to how I personally have done like a case study. Not a case study. So how I have actually assessed the myopia risk for a patient that's in my clinic. All right, so I had this child. This was actually really interesting. Now, she is actually a 6-year-old child, and she came in for her first ever eye test. Now, I won't go too much into the history of it, but she's currently being taken care of by her aunt in a way. And when her aunt brought her in, her aunt was a very lovely person who really cared a lot about her niece. And her 6-year-old niece came in because teachers in school mentioned that she could not see well. And now with 6-year-old, when you get younger kids, sometimes they know their letters well, and sometimes they might not know it as well yet. But she was a very bright girl. I can tell that. Yeah, she was very proper. She was not running around. She was really sitting in the chair, listening to instructions. Honestly, one of the best 6-year-olds I have ever got, probably. Yeah, so she came in because her aunt said, teacher say she can't see too well in school. So we checked her vision, and to our horror, she was barely reading 636 on the reading chart. Now let me try to convert that. So 6 times 6. So that's 2120 for those of you guys, who are using that conversion in a way. Yeah, so she was barely seeing 2120 in her eyes, and it was really shocking. And her aunts actually teared in the testing room when she saw that her niece could barely read that. And of course, here for the driving standards in Australia, in order for you to be driving without glasses, you must at least read the 612 line or the 2040 line. So I told her aunt that, look, if she was at an age where she were to be able to drive, she would not be able to drive without glasses. Yeah, and just to make them understand a bit more about like what we are dealing with right here. But I did get a bit ahead of myself. Let's talk a bit about the family history. So as for the family history, so parents both also do not wear glasses, but she herself studies a lot. And this is something that's really weird, isn't it? If you think about it, like, I mean, it's not really weird, but something that does not happen very commonly for a 6-year-old to really be very engrossed in like reading. She was really studying a lot. And again, like I said, she was a really bright girl. I can tell she's very intelligent, and again, very proper for in terms of the way she presents herself for her age. Yeah, so mom and dad did not wear glasses, and she does spend a lot of time reading books, and studying. Like, she does actually do that. I think she read books more probably. Yeah, that's what the aunt told me anyway. Barely spend time outdoors because unfortunately they don't really have the time to bring her outside. So most of the time she is at home. Even on the weekends, not really that much. And yeah, there is not really much never worn glasses before, so hence. And also the other thing was that, so she is Caucasian in a way. So if you think about it, like, she should be all right, right? But no, like, her myopia at the age of 6 was really like a minus 350. Now, every time I see some sort of a high kind of myopia in younger kids, yes, first thing we do, cyclo, all right? Yeah, so don't forget that cyclo, if it's a first-time patient coming in, 6-year-old or young, never worn glasses, make sure we cyclo them to make sure accommodation is not in play. And yes, we did find that she is a minus 350. And of course, the next thing I did was to check all the ocular health itself, and just to make sure that everything's fine. But before that also, I did check her binocular vision. There was not any kind of tropia. Her lack of accommodation seems fine, so that also did look good. And then check the eye itself, the front of the eye, corneas, everything's okay. Back of the eye, I took a bit more time checking the back of the eye because I really did not want to miss any pathology at all. And thankfully enough, even have like a photo, like an OCT scan of her eyes, everything was fine. Right, so we know that the health of her eyes now is okay, but of course, she's definitely on that slightly higher myopia risk. So I was pretty confident to manage her. And yeah, we did measure her axial length, though I can't recall on the top of my head what was her axial length, but I do know that it is definitely in the higher percentages for the of the growth chart in a way. So that's the reason why we decided to do myopia control. Now, her aunt was ready to really just go all in, like, hey, let's just do whatever that's best for her. And after having a chat, going a bit back and forth, we actually ended up prescribing the myopia control glasses for her because it's her first time. Her aunt is not sure and is not confident that she'll be able to handle contact lenses. So maybe when she's a bit older, maybe when she's 8 years old, we can have a look into it. Yeah, but also because cost was a factor. All right. Over here in Australia, ortho-K would cost roughly about $2,000, maybe a bit more or a bit less. The MiSight contact lenses, roughly in a year, they would have to spend maybe just a bit north of $1,200. But for the myopia control glasses, it's about, I think, less than $700. You might be able to get a pair. Of course, it depends on the type of frame to choose and all that stuff. Yeah. So we decided to do the myopia control glasses, all right, with the aid of atropine. Now, this is really off-label right here because we know that as for now, as of the recording in June 2024, there is no particular studies that show that that atropine plus maybe a myopia control glass can really help to slow down progression. But here's where it is important for you as an optometrist, as an eye doctor, to really make that call. Is it worth for us to try this out, to try this method of like trying to slow it down as much as possible, as much as we can, so that our patient would be able to get the best out of it, all right? So we decided to do daily low dose atropine plus also the glasses on top of it. And I am going to be reviewing her in about 2 months' time, I'm pretty sure, and hopefully we'll have a better idea of where her myopia is sitting at, all right? So as you can tell, that's how I went through it. All the history taking, make sure we ask all those questions, and then we do all the vision assessment check, and then cycloplegia, especially because this is a 6-year-old first time eye test. And then we check the anterior eye, posterior eye, measure the axial length. Yeah, so these are all very important things that we would have to do. And that's what we can do as optometrists. We do what's best for patients, make sure we do all those different tests so that we can see if they are low, medium, or high risk. And for my patient right here, she's a high risk. So we have to be a bit more, in air quotes I'm doing right here, aggressive in terms of treating her and giving what's best for her.